should start. Good afternoon, everyone. My name is Claudia. I am a Master's of Psychology student and also a project coordinator with EPID at Work. So we'd like to start our EPID talk with a land acknowledgement. EPID at Work Research Institute, respectively, acknowledges its location on the traditional lands of Indigenous peoples. We acknowledge we are currently on the traditional lands of the Anishinaabe Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. Welcome and thank you for joining us at EPID Talks. EPID at Work stands for Enhancing the Prevention of Injury and Disability at Work. And here at EPID, we're all about collaborating with and sharing our research with the community. Just a few housekeeping items before we get started. We're interested in hearing your questions and ideas for future research. We have built-in time following the presentation for discussion and to respond to questions. For those who are joining us virtually, please put your questions and comments in the chat. We are monitoring the chat so that you will not be missed. Okay, without further ado, I'd like to introduce you to today's speakers. It's my pleasure to introduce Dr. Nisha Sutherland and Caroline Sabotig. Dr. Sutherland is a registered nurse and associate professor in the Faculty of Nursing at Lakehead University, and her current program of research is focused on the quality of life of people living with dementia in long-term care. She has been conducting an ethnographic study and spending time in long-term care homes. She's also involved in community-based research and is co-facilitator of the Northwest Dementia Working and volunteers at Dementia Cafe, a place to belong. Caroline is a registered nurse and a PhD student at the University of Ottawa. She is the simulation lab coordinator and a contract lecturer in the School of Nursing at Lakehead University. Her research interests focus on supporting healthcare professionals in processing stressful experiences in the clinical setting. Caroline's doctoral research focuses on clinical debriefing following critical events in practice, aiming to enhance staff resilience and learning. Today, their presentation is on moral distress during the pandemic, impact on mental health of long-term care home staff. Please join me in welcoming Dr. Nisha Sutherland and Caroline Sabotig.
Thank you. Hi, everyone. Thanks so much for taking the time to join us here today for our EPID talk. So as Claudia introduced, my name is Caroline Sabotig, and I am the research assistant working on this project with Dr. Nisha Sutherland, who's here as well. So today I'll be discussing moral distress during the pandemic, the impacts on the mental health of long-term care home staff. And just before we get into the presentation, as some of the evidence and the findings that we'll be discussing can be a little bit sensitive or potentially even triggering at times, we just wanted to give a little bit of a heads up to everybody in the audience. Oh, is there?
It's a request to enable the captions.
Can we do captions?
Sure.
Subtitles?
Oh, I think it just says here maybe. Okay, we're defined on it now.
There you go.
Thanks. Okay, so in Canada, long-term care homes were disproportionately impacted by COVID-19 restrictions and regulations in practice. So this led to an increase in everyday ethical situations as well as ethical dilemmas that staff unfortunately experienced. The result of this, in many instances, was that staff experienced moral distress when working during these really challenging times. To further depict the magnitude of this situation, CIHI released data in 2020, as you can see on this graph here. And this data suggests that of all deaths related to COVID-19 in Canada in 2020, 81% of those deaths were in long-term care homes. So a pretty staggering statistic. So this is nearly double the OECD average of 38%, which you can see is the bar just to the right. And the OECD is the Organization for Economic Cooperation and Development. This really helps to set the stage for just how hard and really terrible those working conditions at times were during the pandemic. So as there are many different definitions of moral distress in the literature, we just want to share the definition that we have been working with for this study. So moral distress is an emotional response that arises when workers face constraints on what they can do in their role, and this conflicts with the values and what they know should be done. So why is this a problem? First, it leads to job dissatisfaction. Second, it leads to burnout. And third, it can lead to termination of employment. This, of course, is concerning as we know that pre-COVID, we were already facing a health human resource shortage, provincially within Ontario and across Canada. But that only was further exacerbated as a result of how tough it was for staff working during COVID. The purpose of our study was to gain an in-depth understanding of Northwestern Ontario long-term care home staff's experiences of moral distress during the pandemic and the impact on nurses and PSW's mental health, as well as their resilience and adaptation. So for this study, we recruited all of our participants via social media. So we utilized Instagram and we utilized Facebook for recruitment. Want to just give a shout out to the EPID at Work communications team as they helped us to put together a really eye-catching poster to disseminate on social media for recruitment. And they also helped us to get set up with our targeted paid advertising via social media. So the way that this worked, we were able to actually use geocaching to specifically target the recruitment just to the region of Northwestern Ontario. And I think that we're really pleased to report back that it was a really successful recruitment strategy with all of our participants being recruited using this technique. In addition to that, to collect our data, we conducted in-depth interviews using Zoom, and these on average lasted between 40 and 60 minutes. We collected data between July of 2023 until winter, so like January, February of 2024, so last winter, we had finished collecting all of our data. The analysis that we utilized for this study was a voice-centered relational analysis, and the purpose of this was to critically situate participants' experiences within the context of long-term care and the broader societal structures. Our sample size was a total of 15 participants. So we had 6 participants who were nurses, and they were both registered practical nurses or registered nurses. So our nurses, we had 6 in total. And then we had 9 participants who were working as PSWs. Of the 15, 13 were female, 2 were male. And of the 15, again, 11 were from the city, and then 4 were from the region of Northwestern Ontario. Okay, so 2 main findings emerged from the data, the first being in the battlefield. And this quotation came directly from one of our participants as she was describing just how tough it was working in long-term care and describing those working conditions. The sub-themes under this main finding were witnessing day-to-day suffering, the working conditions that were just, of course, really challenging, the continual stress that was so all-encompassing for staff, and then that common sense didn't prevail. So staff felt that they were enforcing rules at time and also breaking rules at time. The second major finding was the severe emotional toll and psychological impact on staff as a result of what their working conditions looked like and what they were experiencing at work. So the first sub-theme under this was that staff were really questioning their professional identity and their moral integrity. Second, it was really affecting their home life, and this was evidenced by staff just really describing how withdrawn they had become when they were at home, how it affected their relationships with their family. The third theme was that they had, of course, difficulty coping with what they were experiencing and the moral distress. And then the fourth was that no one listened. So they felt really hopeless, helpless, angry, and that they didn't have a voice. So first we'll work through on the next slides, we'll look at the different examples that emerge from this first finding in the battlefield. So the staff were witnessing a lot of day-to-day suffering of the residents, and this was due to all of those, very strict restrictions and regulations that had come into play during the pandemic. The first quotation reads, "I saw a resident just went berserk when she saw her family member at the window. Why can't you come in?" And just like a caged animal, she said, "Why can't I get out?" That was distressing. And then the 6 residents that passed away, that was really distressing. The 1 resident that passed, that I brought home. I know I shouldn't, but I would think about it a lot at home. I would think, what could we have done differently? I went home just crying because I was like, this is so sad. I can't handle this. So this is a really striking example, I think, of how we had these restrictions in place and, the staff were following it as the pandemic, carried on. These window visits became an option, but really it caused a lot more distress for some residents in some cases because they felt like they could see their loved one on the other side of that window. They wanted to feel them, they wanted to touch them, they wanted to connect with them, but they just couldn't. So as a result of this, and of course all the deaths that occurred, there was a lot of distress for this staff member. Another example reads, "They made a rule that you had to have 2 negative consecutive tests 3 days apart. Now we know that some people will test positive for a long time. 12 weeks this man was in isolation. 12 weeks. 12 weeks. When he came out of isolation, I will never forget this. He was a very religious man and he got down on his knees and he literally said, 'Father, why have you forsaken me?' I will never forget that." So again, just another example of how staff were witnessing that day-to-day suffering. It wasn't just one day, it was most days that they were going to work. They were really seeing and feeling and struggling with how these residents were feeling being in long-term care. The next sub-theme is looking at the challenging working conditions. So the first quote reads, "We already only have like 6 minutes and something per client." So when we're understaffed, sometimes that gets shortened. So this PSW is recognizing that at baseline, we only have like 6 minutes, which really isn't a whole lot of time to provide good, high quality care. And then she just started to feel like that number was getting, it was dwindling and dwindling further as their capacity was dropping and they had less staff working. So that was really challenging for her. The next quote reads, "You're required to wear full PPE, like don and doff every time you enter and leave a patient's room." And that might sound like it's hard enough, but then some residents are pressing the call bell 5 times in the morning and you have to don and doff PPE every time you go into the room, so that's definitely hard. This quotation, I think, contributes to the first example of how they already only had 6 minutes. And then as they were donning, doffing PPE, it took away their ability to care even further, or the care was delayed at times and that kind of thing. So that bothered a lot of staff. The third quote reads, "So it hit me harder when they said that it was our fault when COVID-19 spread, because we go home and we stress about coming to work sick. And should we call in? We don't have any sick days left, and if we call in, we don't get paid." So I think this is a good example of a quotation that exemplifies just how betrayed that staff felt at times when they were being told that they were bringing COVID-19 in or they were causing the spread, when they were going home and they were still thinking about it, they were worried about it, they were stressed about it. They didn't want, any residents to be getting sick. And then in addition to that, they also had this inner turmoil where if they didn't go to work, they didn't get paid. So that complicates things further as well. There was also a theme of this continual stress that was just so all-encompassing for the staff. So the first quote reads, "It never ended. Every time I went to sleep, all I would dream about is working a bad shift. It was so crazy. It was just constantly on my mind. Even when I was doing other things, it was always in the back of my mind. It just never left." And this quotation comes from a PSW. And I think that this just really demonstrates how they weren't just stressed and feeling conflicted when they were in the 4 walls of long-term care. They felt that when they left, when they went home to their, their safe space. And this was really, this was hard for these staff and what they had experienced. The next quotation reads, "I would go home and rethink about everything I did that shift and where I could have improved and where I went wrong," which is good, except it just never ended. You're just constantly thinking about the residents and constantly thinking, oh, I did this and that's not how it's supposed to be. Yeah, that's very morally hard. So again, another example how they're just really ruminating on what they've experienced. They go home, they're thinking about it. It's disrupting sleep, it's disrupting connection with family, as you'll see, in the next part of the presentation. It really ate away at them. They were always thinking about it. The third quotation reads, "It just felt like it was an ethical dilemma every day. And I really wrestled with that. First, do no harm. And I knew we were harming people when you have residents telling you, I wish I would die." And this wasn't uncommon. We heard this from a few participants who, the residents were quite vocal with them and saying, I can't live this way. I don't want to live this way. I would rather have more time with my family. I would rather see my family, even if it meant my time might be shorter. And the fourth theme was that common sense didn't prevail. So this quote reads, "People were so focused on following the rules that sometimes common sense didn't even prevail. For example, a husband and a wife who were both residents had to sit with plexiglass in between them in the dining room. And the one spouse was upset and people didn't understand why. This is their spouse of 50, 60 years. They share a bed together, they share a room. Why do they need to have plexiglass between them for meals? Just because it says so, it just doesn't make sense." So a lot of staff felt that these rules that were being imposed and the restrictions on the front lines maybe just weren't practical or didn't make sense. And I think that this is a good example of how this couple actually was sleeping in the same bed. They were in the same room in long-term care, but in the dining room, they had to have the plexiglass between them. And it caused distress. And what this quotation doesn't include is that this resident who was upset was living with dementia. So you can just imagine how that further complicates and amplifies these emotions and, what people were really feeling. So that's an example. Moving forward, this looks at how common sense didn't prevail, but they were still having to enforce these rules that they didn't agree with. So it reads, "There was an article in the paper about how great it was to have window visits. And on the inside, it would be a patient with dementia, and you're saying, your wife has come. He has no idea what's going on, standing 6 feet back from the window, and he probably can't even see her, can't read lips if they're hard of hearing, has no idea what's going on. And there's people taking pictures like this is a great thing. They think he's excited. Really, inside he's screaming because people are forcing him to hold onto a phone." So again, an example of how, especially in a resident living with dementia and with some visual impairment, they didn't understand what was going on. And this was more distressing for the resident. So then again, the staff is witnessing the distress and suffering of the residents. The next quotation reads, lots of calls from family, lots of yelling at us because they wanted to see their family members and why can't they? And trying to explain the rules and I don't know why they're in place. Pretty much we were just getting yelled at for 2 years. So an example from one of the nurses, how as the frontline staff, they were getting the brunt of what the family felt. They were feeling the frustration and, they were on the receiving end of this anger for these restrictions that they were enforcing, but they didn't necessarily agree with. Or, they went on for so long, in this case, like for 2 years, it just felt like it was never ending. And then finally, we have when staff were now in a position where they were breaking rules. So because we were so short-staffed, I was asked by management if I'm okay after 5 days. If I'm feeling better to come in to work, then I can take care of COVID positive patients since I already tested positive. So as times went on, and in response to staffing crises, staff were being asked to come in when they were sick after 5 days of having COVID. They would be asked to work with the COVID positive residents in long-term care. But then staff really struggled with that because it's like, I'm coming in sick. Yes, I'm working with the residents who also have COVID, but family members who are testing negative can't see residents who are testing negative, and it really bothered them a lot. We'll move on to the second finding. So the findings that are related to the severe emotional toll and psychological impact that this had on staff. The first theme looks at how staff were really questioning their professional identity and their moral integrity. So this first quotation reads, "It's so hard to put into words, it just felt wrong. It felt like I was going against everything that I'd been taught before, so obviously it was stressful. I felt like I was being a bad person. I felt like I was being a bad nurse, or I guess PSW. Yeah, it felt like I was doing the opposite of what I was supposed to be doing, which was promoting independence and giving them proper care. I felt like I was cheating them out of something because they deserved way better." So she's struggling here and she's feeling that she's not living up to the professional standards that, she was taught to, you know, comply with or work with. And she felt that she wasn't working as the PSW she wanted to be working as, but they were so maxed out in just that capacity that they weren't able to due to all these restrictions. The second quote reads, I felt awful because I'm a very empathetic person, and that's probably why I went into the nursing field. And if I feel like I'm not taking care of these people well enough, then that kind of makes me feel bad about myself and I feel bad for them. So again, another example of just how their moral integrity, they felt they were questioning their moral integrity and who they really are at this point and what they're here doing. And that's a really strong example of how the moral distress was really coming through. Then their home life was also affected. So they were withdrawn at home. Like I said, relationships were impacted. There was a lot, conflict in some cases. This first quotation reads, when I came home, I was thinking about work. Even though I enjoyed gardening, I would sit out there and I felt like I couldn't enjoy it. I felt like an empty shell. I was useless sitting at home. I think it's because you get used to working so much that when you try to stop, you can't. It was horrible. I was totally disconnected from my whole entire life. I felt like I had no purpose in life anymore. When I was at home, I couldn't connect with my family. I felt like I didn't belong anywhere. So that just paints such a vivid picture for how much they were really struggling. And again, this didn't stop when they walked out of their job at long-term care. This carried on and this was affecting them at home. She's saying how she felt like a shell of who she used to be, and she was disconnected from her whole entire life. So really impactful. The next quote reads, and even on TV now, if something has to do with COVID, like one of my TV shows, I have to shut it off. I'm like, this isn't even real. So yeah, I still have some work to do. So I think recognizing that, and again, just to remind folks, this interview with this participant in particular was actually last winter. So like in winter of 2024. And she's still saying, if I see something on TV with COVID, I have to turn it off because it's just so triggering for me. And it brings back these really terrible times and memories and distressing experiences. Staff also had difficulty coping. So first quotation reads, I mean, residents would get mad at us, so I was the sounding board for them. I just let it wash off me to the best of my ability and go home and have a vodka. So, this nurse is, again, she's taking the brunt of these rules and restrictions and the frustration from families, and then going home and she's having a drink to kind of cope and process it. The next quotation reads, I started taking Zopiclone, I couldn't sleep, and that went on for probably like a year. And then I was like, okay, I don't want to take benzos, so I switched to mirtazapine. And I took that for a year, and then now I'm not taking anything. But yeah, I had to. I needed sleeping pills, I couldn't sleep. So this nurse actually was explaining how while she was working there, she was in such a position where she couldn't even sleep. She was so distressed, and she did end up leaving long-term care. And she said, now I'm not on sleeping pills anymore. But while I was there, I had to, this is what I needed to help me. The third quotation reads, there was a point that I was already ready for work. I was already in my scrubs and I was already waiting for my bus. I just couldn't take it. My shift started at 11. I called in at 10:55. I was very apologetic to the nurse. I was like, I'm so sorry, I just can't. If I go to work right now, I think I would be more of a liability. And it's so not me to be calling in. I just can't. I'm not in the headspace anymore to be at work. I was too burnt out. Yeah, I just don't want to do anything. So again, an example of how this individual isn't even recognizing that they're no longer coping until 5 minutes before they're supposed to be at work, they're calling in sick. So it was pretty extensive and they struggled to cope with what they were facing. The final theme here was that no one listened. So they felt hopeless, helpless, they felt abandoned. Nobody checked in, nobody asked how things were going. A lot of staff really shared that with us. The first example reads, so many of the staff felt it was wrong. We would talk, we all felt it was wrong, and everybody said it. No one cares. No one listens to us in long-term care. No changes come. That is how people feel in long-term care. So again, feeling like they weren't heard, they didn't have a voice. The second example reads, I'd get in trouble or my coworkers if we tried to do group activities. It was very frustrating when you'd have a good idea and you'd share it and it didn't follow the rules, so it was kind of kiboshed. Even recreation suggested all the people in their rooms doing bingo, but our care home said no for resident safety. But at the same time, that also would have brought a sense of belonging and something fun to do. We were all trying our very best to get some activities other than sitting in their room. We're there to make people feel better. This is their home, and it felt like we were putting them under house arrest. So for more context, what the PSW was, asking for, advocating for, was that residents would all sit in their individual rooms, but in the doorway, and they could kind of play bingo. Like the staff would walk up and down the hall and call bingo, and they would be able to engage in some sort of sense of community here and what was, supposed to be their home. But even that wasn't allowed, and staff just really felt hopeless and helpless because of it. Third, the last quotation reads, we felt like you guys thought we were the heroes in the beginning and then all dropped us like hotcakes, forgot about us. Did you really care about us? And I think if you have a good staff, you'd want to make sure you kept them and make sure that they're mentally okay. And I kind of felt like they just didn't provide any support for us. So staff just really feeling first and foremost like they were the heroes and everybody really respected what they were doing and was so supportive of it. But as time went on and on and on, as the pandemic continued on and on and on, they felt like they were just forgotten and dropped. And then they also felt like, why is nobody checking in to see if we're doing okay with what we've been experiencing? Like, this has been really hard to work through. So I think the key takeaway is that we need to support these staff. They supported us in long-term care. Now it's time that we make sure that they're okay as well. So what we've found is we're thinking that this is beyond moral distress in some cases, leading towards even moral injury. So as evidenced by, again, affecting their home lives, their relationships. They were so withdrawn. They were just a shell of who they used to be. Their loss of professional and personal identity and how they just really questioned who they really were, how they felt helpless, hopeless, and they even felt angry as time went on. Second, staff just had no voice to discuss the frontline effects of these rules and regulations. They felt like they had no one to tell. No one heard or listened to them. No one checked back in. And if they tried to speak up, there were cases where they felt that they were, getting into trouble at work as well. So, we'll move on to implications. So first, we think that it's important to just have this awareness of the emotional and psychological impact on staff. And that, again, we conducted these interviews in 2023, 2024, and this is what staff were still telling us they were feeling. So in some cases, some folks are still certainly struggling and working through what they experienced. Second, to include frontline workers in policy and decision making. So they need to have a voice, they need to have a seat at that table. They're the ones who are, again, enforcing these rules day in and day out and living it. So they need to have more of a voice in it. Mechanism for whistleblowing. So we don't know much about the whistleblowing literature, but thinking that would that be a helpful way when things were just really not, they weren't comfortable with what was going on. Could this be a way that they could speak up? Fourth is regular debriefing. So some staff in the interview say they wish that they had had more debriefing to help process and work through what they had experienced. So, potentially looking at implementing that more regularly and creating more of a debriefing culture. And then finally, providing this ongoing mental health support. So again, recognizing that some people might still need some support and circling back to see how can we bridge that gap that now kind of exists. So that's our presentation. Thank you so much and excited to get into the discussion period. Chat. Oh, you have it. Perfect.
I don't see any questions online. Is there anyone else here who has any questions, thoughts?
It was very insightful. Thank you for sharing. My question is when you interviewed them, were there any mental health outcomes, any formal diagnosis? So from the scripts that you shared, the transcripts, it looks like they are still having those flashbacks or those kind of symptoms. So I would somehow relate it with post-traumatic stress disorder. So did they receive any formal diagnosis?
I don't recall anything in the data that they really provided any, like a formal diagnosis of where they already were. I do recall a couple of participants saying like, you know, they were already engaged with a counselor or a therapist pre-COVID, but they found that they were leaning on that more. Another participant said like, I had anxiety and depression, but it just really worsened and exacerbated it. But yeah, we were wondering if we're seeing some components of PTSD as well. Yeah.
Right. One more question.
Yes.
Like regarding your methodology, I think I've missed this, but within like qualitative, was it, which approach did you use?
I'll turn that to Nisha. She's the expert in this methodology.
Well, we use a relational centered analysis. And so instead of just looking at perspectives of individuals, we looked at the individuals and the relationships that they have with themselves. You know, how do they talk about themselves? And then the relationship they have with others, how do they talk about other people? And the relationships that they have with structures of and organizations like the long-term care home, the policies, and even like a hierarchical structure, because long-term care is very hierarchical. So really looking at power relationships.
Thank you.
Thank you. Yeah, Claudia.
Yeah, so kind of more so from the perspective of the researcher, I imagine hearing these stories is also distressing, like during these interviews. So do you have any recommendations for like kind of future researchers who might take on similar work to protect your own psychological well-being as well, like doing this type of work?
Yeah, that's a really great thought. So we had started the analysis, you know, throughout last year, and then of course, you know, continued and then in preparing for today and looking at preparing manuscripts as well, where we revisited the data and we both said to each other, like, this is really hard. And I think that that was where we decided that we need to like, you know, share that with the audience before we start with our participants here today. So yeah, in terms of moving forward for future research, I think it's important that we think about how we can protect the researchers as well who are experiencing this and having these conversations. And I think from the quotations, you could probably get a sense of just how much emotion was really in those participants' stories and their voices as they were sharing this with us. So yeah, do you have anything to add to that, Nisha?
Well, interestingly enough, we were also doing another study in long-term care. Caroline was a student for that too. So we were in long-term care and seeing things and also doing analysis for this. And we did debrief and actually it's funny, we had left this analysis for a while and came back to it and went, oh my gosh, like it affected us again. And maybe we were a bit numb to it at the time, maybe when we were in long-term care. But we did try to have some debriefings.
Yeah.
And talk about how this affects us, because it also affected us being in long-term care, because we had gone just when it had opened in COVID-19, and there were still masks and still a lot of screening and things like that. So we were still feeling it then. But a great question.
So there are a couple of questions online. Sylvia asked, was it tracked if these healthcare workers were employed at private or nonprofit or long-term care?
So some didn't even disclose where they were actually working. So we don't know the extent of it, and yeah, we don't know.
Another participant asked, how many of your sampled participants were visible minorities?
There seemed to be a couple.
Yeah.
From English. I just wanted to talk back to the other question when you were asking about the long-term care homes. I think I just want to point out that some people didn't want to disclose because it is very hard to say that you had witnessed this suffering and you actually didn't do anything about it. And that, you know, that you're kind of admitting to yourself that, you know, you didn't meet up to your own moral integrity. So I think maybe that's why a lot of people didn't ask. But we did have a lot, we had 11 within the city of Thunder Bay. So they were the bigger homes.
Questions online? Anyone, any more questions from anyone?
Jacqueline, I can advance it to your final slide here as well.
I just had like, just wondering like, so the people, the participants, the number was 15. So did you know, like, maybe I missed it, it was a great presentation. Did they have pre-existing mental health or well-being impacts or effects before they took part in the study? And if they took part in the study, did it enhance their mental health? And if they did, what other steps were they doing to mitigate those issues?
Good question, yeah. So I don't think that we, you know, some participants disclosed if they, you know, they've been previously seeing attending counseling or therapy, and then that continued or, you know, picked up, increased throughout the pandemic. I think a couple maybe mentioned having, you know, I had anxiety and depression, it definitely got worse. But I don't think we really had a baseline of if there was.
We weren't really expecting these findings. We were looking at moral distress and but we weren't really expecting the impact. But that would have been good to know.
Yeah.
I just thought it was interesting because you did like kind of COVID-19. So, you know, like I was probably one of the guys that was outside their grandmother's window on the third floor, kind of like waiting up and kind of wondering what was going on and type of thing. So it was kind of interesting, kind of insight on the impacts that the nurses were feeling. And it kind of makes you wonder, what also what administration, what impacts and effects of administration was feeling, because they were making the higher decisions. Was there like, were they all for it, or was there dissension, or did they barely, you know, that kind of it. So it's just an interesting.
Good point.
Thank you.
Oh, there's one more question. Did the majority of participants continue to work in long-term care or at the same workplace?
Can you repeat that, please?
Did the majority of the participants continue to work in long-term care or at the same workplace?
Some people had quit.
Some had left and yeah, some had stayed. Sure.
I think that's everyone. Thank you so much.
Thanks so much for being here with us today, and everyone online as well. Thanks for coming.
Oops, sorry. And I'm told that the link isn't working, so we will send out an email to everyone with the correct link for the survey. But thank you so much.
Thanks for having us.
Sharing with us. Have a great day, everyone.